So I'll be doing hypercalcemia and hypokalemia now. So hypercalcemia is defined as an increase in the serum calcium more than 10.5. So whenever you're talking about the serum calcium level, always remember you need to measure the corrected calcium. So for albumin, for every decrease in 1, you will have to increase the calcium by 0.8. The factor is 0.8. So remember that. So serum calcium more than 10.5 milligrams is defined as hypercalcemia. And symptoms become evident when the serum calcium levels is more than 12 milligrams per deciliter, or if the ionized calcium levels are more than 3 millimoles per liter. Okay, the most common etiologies are primary hyperparathyroidism or hypercalcemia of malignancy. So these are the various causes. So primarily think about the parathormone increase. Okay, it can be parathormone production can be high. So when does that happen? It can happen in primary hyperparathyroidism due to any adenoma or hyperplasia of the gland. Tertiary hypoparathyroidism. When does this happen? So patients with renal failure, what happens is that there will be kind of low calcium levels which causes feedback, and it causes increase in parathormone. Ultimately, there can be hypertrophy leading to high parathormone secretion. Okay, that is one. And patients with alteration in the calcium sensor receptor function and lithium therapy. So these are associated with high parathormone production. Next is hypercalcemia of malignancy. This is due to overproduction of the parathormone related peptide. So this can be produced by many solid tumors, and others like breast, myeloma, all those things can cause lytic lesions in the bone, which can result in bone resorption. So diseases like granulomatous diseases like TB, sarcoid, silicosis, all those things can cause excessive 125 dihydroxy vitamin D production. Also lymphoma can produce. Okay, in vitamin D intoxication, this levels of 125 dihydroxy vitamin D will be elevated. Primary bone disease or bone resorption happens in hyperthyroidism, immobilization. Excessive intake of calcium, milk alkali syndrome, TPN. Other thing, remember hyperthyroid, pheochromocytoma can result in hyperthyroidism. And also medications, thiazides, vitamin A, anti-estrogen. So these are the etiological factors. So clinical features, what happens? Mainly neuronal issues, or patients will have CNS disturbances. That is the main thing. Why is that? Alteration in the charge balance across the membrane, because the neuronal cells need sodium. Actually, the sodium channels on the neuronal membranes become more resistant to opening because of hypercalcemia. So they have to, the threshold potential goes up actually. So that is the reason why there is a new decrease in neuronal action potential, and then there is sluggish neuronal activity. So the cognitive dysfunction happens and coma. And there is also neuromuscular dysfunction. Okay, junction, there is fatigue and weakness. So calcium can precipitate along with phosphate throughout the body. So anywhere, urinary tract, resulting in renal stones, flank pain, and all that. So calcium inhibits insertion of aquaporin channels in the collective duct membrane. So there is less water that is reabsorbed, and increased, there is natriuresis, there is high volume of urine that is produced, and ultimately dehydration. So these are the effects. One is CNS effects, another stones, and third one is dehydration. So how will you manage? So management, first get a detailed history. Okay, what is a family history, drugs, and malignancy related. Next is look into the serum parathormone levels. If the serum parathormone levels are elevated, it can be primary hyperthyroidism. If it is normal or low, then evaluate for non-parathormone related hypercalcemia. So look into uh, parathormone related peptide, 125 dihydroxy vitamin D, 25 dihydroxy vitamin D. So these three levels. If parathormone related peptide is elevated, it can be more likely due to malignancy. If it is not, then look into 125 dihydroxy vitamin D. If this is elevated, it is more likely due to some granulomatous disease or lymphoma. If not, look into your 25 hydroxy vitamin D. If this is elevated, it is more likely vitamin D intoxication. If none of the things are contributing, then look into your protein electrophoresis light chain assay. So this can point towards a myeloma, multiple myeloma. So assess for other causes of hyperthyroidism also. Okay, how will you treat hypercalcemia? If it is mild hypercalcemia less than 12, moderate 12 to 14, hydration is the key factor. Okay, avoid other factors that can aggravate hypercalcemia like thiazide diuretics, lithium, avoid volume depletion, and stop any calcium supplements. If severe hypercalcemia, if it is more than 14, then isotonic saline along with diuretics like furosemide you can initiate. So isotonic saline, how much you should give? 200 to 500 ml per hour to maintain a urine output. Target a urine output of 100 to 150 ml per hour to promote renal excretion. So the delivery of calcium to the kidneys will be increased and it promotes calciuria. Okay, there is osmotic diuresis and the main mechanism will be kind of treated. In volume overload states like hepatic failure, renal failure, you should be very careful while giving the fluids. Furosemide, the dose is 40 to 80 milligram IV 12th hourly to maintain the urine output of 100 to 150 ml per hour. So the rationale of giving furosemide is it does not correct hypercalcemia and 70% saline infusion alone does not promote. Furosemide is needed for urinary excretion. So, but it is recommended especially in patients who are at a risk of developing volume overload. So the next medication what we can use is calcitonin. Calcitonin is given as a subcutaneous form, 4 milligram per kg, 12th hourly. It can be increased up to 8 units. It can be increased up to 8 units per kg every 6 to 8 hourly. Normally, we give up to 200 to 250 subcutaneously. But the problem with calcitonin is that tachyphylaxis occurs. So beyond 40 to 48 hours, the effect of calcitonin disappears. So the mechanism by which it acts is it inhibits the bone resorption, increases renal calcium excretion. Next is glucocorticoids. Hydrocortisone can be given 200 to 400 milligrams per day for next 3 to 5 days. It increases the renal excretion of calcium, decreases osteoclastic activity in the bone, and decreases renal production of calcitriol in lymphoma and myeloma. The last one is bisphosphonates, which is very useful in cancer-related hypercalcemia, malignant hypercalcemia, zoledronic acid and pamindronate. So, but the onset of action is going to be too late, 24 to 72 hours, but the duration of action will be 2 to 4 weeks. So it can be kind of given at an intermittent period. Zoledronic acid 4 to 8 milligrams IV over 15 minutes, pamindronate 90 milligrams over 2 hours. So this inhibits bone resorption and interferes with the osteoclast recruitment function. Denosumab, so this is also used where bisphosphonates are contraindicated and refractory hypercalcemia is present. So the dose is 120 milligram once a week subcutaneously. So this inhibits the rank, okay, the receptor activation of nuclear factor kappa beta ligand. So this inhibits the bone resorption. Last option would be to proceed with dialysis. If there are severe symptoms and the concentration is very, very high, proceed with dialysis. So next, we'll be looking into hypokalemia and hyperkalemia. So it's very easy, I suppose. So hypokalemia is mainly potassium. It's a main intracellular component, mainly present 98% in the intracellular compartment. The degrees of hypokalemia, you can term it as mild, moderate, and severe. Mild is 3 to 3.5. Moderate is 2.6 to 2.9. Severe is less than 2.5. So when you're talking about the etiology, you can broadly classify into two. One is decreased intake. Second, redistribution into the cells. Third is increased loss. So decreased intake mostly due to starvation. Redistribution, when you're talking about redistribution, it can happen in various due to various reasons, mainly insulin, okay, insulin, beta 2 activity, especially post MI patients who are receiving post MI, post TBI, alpha adrenergic antagonist. So theophylline, caffeine, okay, metabolic alkalosis, and anabolic states wherein vitamin B12, folate administration, any GCSF administration, TPN, refeeding syndrome, and other factors would be pseudo hypokalemia. When does pseudo hypokalemia happen? Because of high WBC count, okay, high leukocytosis or thrombocytosis also. Increased loss either renal or non-renal. Non-renal diarrhea, sweating. Renal due to diuretic salt wasting nephropathies. Increased secretion of potassium also happens in these syndromes: Cons, Cushing's, Barter's, Gitelman's. Okay. So other causes, type 1, type 2 RTA as well. Okay. So when you're talking about the clinical manifestations, one is cardiac arrhythmias, which is very important. Next, intestinal motility, neuromuscular weakness, hypokalemic periodic paralysis can happen. Other one would be rhabdomyolysis, myopathy related rhabdomyolysis. So cardiac arrhythmias, most common is atrial. So you can find there is T wave inversion and prominent U waves. Okay, this is the most common feature. There can be atrial ventricular arrhythmias and QT prolongation. It predisposes to digoxin toxicity. So when the patient is on digoxin, you need to make sure the potassium levels are normal, because digoxin and potassium share a common binding site on the cardiac membrane, that is sodium potassium ATPase units. Okay, muscle pain, it can result in cramps, myopathy, and rhabdomyolysis. It can cause hyperpolarization of the skeletal muscles, impairing capacity to depolarize and contract, which will result in hypokalemic periodic paralysis as well. And gut, you can have gastroparesis, paralytic ileus, and pseudo obstruction as well. So how will you evaluate hypokalemia? So if the serum levels less than 3.5, first see if it's an emergency. If it's an emergency, patient is having T wave inversions, U waves, then move to therapy. Okay, and rule out pseudo hypokalemia. So if it is pseudo hypokalemia, no further workup. Then examine the patient, get a clear history. And if there is evidence of low intake, supplement. And see in for drugs or any other causes that can cause a transcellular shift. For example, any insulin infusions or TPN or whatever is going on, and treat accordingly. Next step would be look into the urine potassium. If the urine potassium is low, that means there is a extrarenal loss that is going on. Example, diarrhea or patients with excessive sweating, cystic fibrosis or something wherein there is a loss of burns. So loss of potassium in the extrarenal part. urine potassium more than 30, then you look in for your TTKG. So this urine potassium multiplied by your serum osmolality divided by blood potassium, serum potassium into urine osmolality. If this TTKG is more than 4, that means renal wasting is happening. Okay, if renal wasting is increased distal potassium secretion. So this could be due to various etiology. So the etiologies being renal secreting tumor, malignant hypertension, anything that can result in acidosis, especially RTAs like RTA, proximal distal RTA, Gentleman, Cons, and Cushing syndrome. So these will be associated with high blood pressure, malignant hypertension, Cons, Cushing's. So these are the various syndromes that can result in high TTKG. If there is low TTKG, it means increased tubular flow and osmotic diuresis. So if the urine potassium is high, also looking for associated hyperchloride chloriduria. So if the urine chloride is also very high, it is mostly due to diuretic therapy or magnesium depletion. So it means you need to supplement magnesium also. So magnesium is an important factor for reabsorption of potassium. So if the urine potassium and chloride is also high, so supplement with magnesium. If the urine chloride is low, then it could be due to some other loss. So goals of therapy. So prevent arrhythmias, paralysis, rhabdomyolysis, and any respiratory weakness. Correct underlying cause. Eliminate what will be the causative or etiological factors. Mainstay. So remember, whenever there is 1 milliequivalent decrease in the serum potassium levels, the body deficit is going to be huge. The body deficit is going to be almost 200 to 400 milliequivalents. So in mild hypokalemia, what happens usually it produces no symptoms, but you need to be very careful in patients who have heart disease, digoxin, and antiarrhythmic agents. And in cirrhosis, it can precipitate hepatic encephalopathy. So in patients with GI losses, especially associated with metabolic alkalosis and concomitant potassium chloride depletion, that means the patient is having a high RT aspirate. So that is resulting in contraction alkalosis and chloride deficient. In that scenario, go in for an IV supplement. Okay. So in diarrhea, GI intolerance, IV supplement is needed. Nasogastric or oral supplement 40 to 60 milliequivalent increases the serum levels by 1 to 1.5 milliequivalents per liter. Patients who are on diuretic, chronic diuretic therapy, or patients who have primary hyperaldosteronism, then consider ENaC blockers like amiloride, which can be given at 2.5 to 10 milligram per day, max of 40 milligram. And mineralocorticoid receptor, eplerenone and spironolactone can be considered. So moderate to severe hypokalemia give IV potassium chloride. You can also consider potassium phosphate if associated phosphate is low. Okay. The potassium phosphate, 1 ml contains 4.4 milliequivalents of potassium and approximately 3 milliequivalents of phosphate. Okay, and how much you should give through a central and a peripheral line. So your dilutions, so these are your dilutions, and maximum rate of infusion through your peripheral line should be should not be more than 10, max 20 milliequivalents per hour. So 10 milliequivalents per hour is the recommended infusion rate, wherein through your central line 20 milliequivalents per hour, you can go up to a maximum of 40 milliequivalents in emergencies, and never diluted in dextrose-based solutions. Next is hyperkalemia. So hyperkalemia grades mild, moderate, and severe 5 to 5.5, 5.5 to 6, and more than 6. So the etiology, redistribution, again the shift, transcellular shift, inadequate excretion by the kidneys, and pseudo hyperkalemia. So when we are talking about redistribution, there can be acidosis, which can result in hyperkalemia, hyperosmolality, hyperglycemia, mannitol, beta-2 antagonists, succinylcholine, hyperkalemic periodic paralysis, cell lysis, okay, hemolysis, rhabdomyolysis, tumor lysis syndrome, and blood product transfusions. Drugs like ACE inhibitors, ARBs, okay, again amiloride, so spironolactone, all these things can cause renal insufficiency, AKI or CKD, type 4 RTA, and drugs like heparin, cotrimoxazole. So these are the main etiological factors for hyperkalemia. Clinical manifestation, you can divide it into again cardiac, skeletal muscle, and renal. So cardiac arrhythmias, when you are talking about the various levels, have various impact. For example, 5.5 to 6.5, up to that, there can be peak T waves. Next, it will be progressing to atrium. So there is P wave that is widening, P wave flattening, and PR prolongation, and P waves eventually disappear. So next, beyond 7, there can be bradyarrhythmias and conduction blocks of various grades, okay? And there is QRS prolongation with bizarre QRS morphology. If it is more than 8, the patient can go into any sine wave pattern, ventricular fibrillation, asystole, or PEA, cardiac arrest. Okay, those are related to the cardiac symptoms. In skeletal muscle, there can be decreased conduction, so muscle weakness and paralysis. So in renal system, less hydrogen ions are excreted due to hyperkalemia. In the proximal tubule, it interferes with glutamate deamination. So thereby, there is decreased H plus excretion, resulting in metabolic acidosis. Thereby, the patient can have high respiratory rate. So how will you diagnose hyperkalemia? If it's more than 5.5, see if it's an emergency. Is the patient having ECG changes? Treat immediately. If it is pseudo hyperkalemia, no further action is recommended. If and careful history taking, physical examination, and other lab tests. So if there is a history of increased potassium load, if the patient is on supplement, reevaluate and stop it. If there is evidence, if some factor is causing transcellular shift, treat that appropriately. Next, look into urine electrolytes. Look into the urine sodium. If the urine sodium is less, it means there is a decreased distal sodium delivery. Okay, this is important because hyperkalemia can be due to decreased sodium delivery to the distal tubules, which can cause decreased elimination of potassium. Okay, this happens because of many extrarenal causes like hypovolemia, dehydration, patients with nephrotic syndrome, cirrhosis, hypoaldosteronism. So due to decreased sodium delivery to the distal tubule, there can be decreased potassium excretion resulting in hyperkalemia. Then look into your TTKG. Here, if the TTKG is more than 8, that means there is reduced tubular flow, and the cause is being extrarenal here. And if it is less than 5, if TTKG is less than 5, it is renal cause. So it can be acute glomerulonephritis, tubulointerstitial diseases, mineralocorticoid antagonists, or any trimethoprim or adrenal insufficiency. So that's about your diagnosis. Then management of hyperkalemia. So immediate management to prevent cardiac effects is IV calcium, because it stabilizes the cardiac membrane. Okay, it increases the cardiac action potential, reduces the excitability without changing the resting membrane potential. Okay, and reversing depolarization block due to hyperkalemia. So these are the mechanisms by which IV calcium acts. So how should it be given? 10% calcium gluconate, 10 ml over 10 minutes. Okay, and onset of action is very quick, 1 to 3 minutes, and it persists only for 1 hour. So remember, within 1 hour, you'll have to make sure other measures are employed or instituted. So calcium chloride, it has a higher concentration of calcium. So calcium, and also remember, calcium potentiate digoxin toxicity. So if the patient is on digoxin, you need to be very careful when you're giving IV calcium. So other mechanisms by which you can reduce potassium is by causing transcellular shift. So insulin dextrose infusion. So 25% dextrose with the 10 units of regular insulin, 100 ml. The onset of action will be 15 minutes and the duration will be almost up to 6 hours. So you need to keep on repeating until you correct the etiology. Your sugars can go up, make sure it's kind of maintained. 50% dextrose ideally not recommended because it's hyperosmolar. Next would be beta 2 agonists like salbutamol. So onset of action is 30 minutes, duration is 2 to 4 hours. Side effects being tachycardia and hyperglycemia. In cardiac patients, you need to be very careful. Next drug would be soda bicarb. Is it really recommended? Okay. So currently no role in acute treatment of hyperkalemia, but in patients with concomitant metabolic acidosis, yes, soda bicarb can be given. So 50 to 100 milliequivalents IV or 150 milliequivalents, either an iso bicarb, like 150 milliequivalents in 1 liter over 3 to 4 hours can be given. Okay, removal of potassium. So removal of potassium is by 3 mechanisms. One is sodium or calcium polystyrene sulfonate. So it increases the stool excretion, exchanges sodium for potassium in the GI tract. Other resins, all those things, 15 to 30 grams hourly, onset of action being 1 to 2 hours, and peak action takes long time, like 24 hours. So avoid in patients with ileus or constipation, increased risk of intestinal necrosis. Loop diuretics, 40 milligram IV stat followed by an infusion if it is needed. Onset 5 to 10 minutes and the duration of the duration of action will be 2 hours. It can be used in volume overload status. Okay. Hemodialysis in severe renal impairment. Okay. This is one of the method for removal of potassium.